welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Sangeeta, and for this episode, I'm delighted to have with me today Honorary Consultant Physician, Dr. Glenis Scadding. Glenis is a specialist in allergy and rhinology, and she's presented and written for us loads of times in the past. It's good to have you back with us, Glenis.
Thank you very much.
Can you tell us a little bit more about yourself?
I've worked in the NHS as an allergist in an ENT hospital for over 40 years. And during that time, I have really enjoyed interacting with my fellow ENT surgeons. And I think that by doing combined clinics, we have improved the lives of patients considerably. They don't get bounced from one specialist to another. In future, many other ENTs would be wise to adopt a physician, an allergist or a chest physician, and work with them, and patient satisfaction will improve enormously.
And at the time of recording, we're just coming into the hay fever season. So what are the trends that we're seeing in the UK? Is hay fever becoming more prevalent, and is that associated with climate change?
Certainly, hay fever is becoming more prevalent. 200 years ago, it was a very rare disease of the upper classes. And now something like 1 in 4 people is affected. We think there are 2 major forces behind that. One of them is the microbiome, the organisms that live with us, in us, and on us, particularly the gut ones, that help to direct the way our immune system reacts. And the other factor are sort of westernization factors acting on our epithelia. Things like pollution, PM25, detergents, microplastics, which can damage our epithelia, alarm them, allow in allergens and bugs, and engender a reaction. Because allergy is actually a misplaced immune reaction. It's the immune reaction that we should use to get rid of big organisms like parasitic worms. So it is an immensely powerful reaction, but it's being misdirected to harmless molecules like pollens, and thus causes hay fever.
What should a practicing GP be looking out for?
Well, patients at this time of year who turn up with runny itchy, sore eyes, sneezing, runny, blocked noses, and whose symptoms disappear when the pollens disappear.
So the symptoms are quite similar to some other conditions. So how can GPs distinguish between hay fever and these differentials like viral infections? Are there any red flag symptoms to look out for?
Okay. The major differential between hay fever and viruses is that hay fever involves itching and the eyes are very often involved. There are 2 major things to look out for. Viruses tend to start with a sore throat, and with virus you often feel much iller than you do with hay fever, although hay fever can make you tired because you tend to sleep poorly. Certainly there are red flags, unilateral symptoms, pain, bleeding, heavy bleeding in the nose, really heavy discoloured secretions are unlikely to be simple hay fever. There is an emergency situation, which is orbital cellulitis. The eye that is swollen, throbbing, red is absolutely an emergency, and that patient needs to go to A&E rapidly.
What are the different triggers for hay fever?
For hay fever, it's pollens. Tree pollens now in the springtime, grass pollen between late May and the end of July, and then in the autumn, weed and mold pollens. So if you're sensitized, that is, if you have IgE to all of those, you could be symptomatic from early January until October.
Now, the Met Office gives these pollen warnings down to the specific type of pollen. So, do you encourage your patients to check this data and make use of it when it comes to taking medications to manage their symptoms?
Yes, to an extent. It's always good to start medication before your symptoms start, to use it regularly every day without fail, and only to stop it when your symptoms are likely to go away because the pollen goes. So the Met Office can be useful for tracking that. I also encourage my patients to use Mask Air, which is a mobile app that you can record your symptoms on. And that can be very useful when you go to your GP to say, look, my symptoms began then. The GP can look up and see what the pollen was and what you're likely to be allergic to.
Oh, that's very useful to know. What are some of the diagnostic tests for hay fever? And is it easy to access them within the NHS?
They're not terribly easy to access within the NHS. The tests involve looking for the allergy antibody IgE, either by skin prick testing or by blood testing. But actually, for most hay fever patients, they are not actually necessary. A good history of symptoms occurring in relation to pollen, going away when the pollen goes, is good enough to have a trial of therapy. And that's what I suspect most GPs do, because that makes life quicker. Very few GPs do skin prick testing in their clinics. I would love them to do it, but they just don't have enough time. And sending away a blood test is fine, but it takes time, it costs money, and actually try and go on the history, examination, always look up the nose, always test the chest, is enough for most patients.
And can you talk about the management options?
Yes. First things first are that if the patient knows what they're allergic to, they should avoid it as much as possible, and also avoid the adjuvants, the triggers that make things worse. Things like cigarette smoke, bonfire smoke, perfume. And so stay indoors when the pollen levels are high. Bring your washing in before the pollen comes down in the evening. Wash your nose out with saline if you've been out somewhere where you've been exposed to a lot of pollen or pollution. Simple things like that. The other thing that works, and this was shown during COVID, is that wearing a mask reduces hay fever symptoms quite dramatically. So if you have to go out, put on a mask. So those are all things patients can do for themselves as a start. Then we're into therapy. Most patients will go to the pharmacy and ask the pharmacist for advice or choose something. The majority will choose an antihistamine. The important thing is that it is not a sedating antihistamine. No sedating antihistamine should ever be used for any form of allergic rhinitis. If they are fine on that, okay, they'll never need to see their GP. Most patients who actually reach the GP have moderate to severe disease, and what they will need is more effective therapy. And that is usually an intranasal corticosteroid spray. If they are over, I think it's 12 now, the age varies according to time, and they should be shown how to use it, and they should be told to use it regularly every day without fail. If they're too young for that, an intranasal antihistamine spray is twice as effective on nasal symptoms as is an oral antihistamine. So that is a good step up for the children who are not responding to oral antihistamine. But again, always with a spray, teach people how to use it.
Yeah, that's what I was going to get to next. Patients' techniques for applying the intranasal spray can be a hit or a miss. So, do you have any tips?
There are some very good videos online. I work for an organization, a non-profit organization called Euphoria, EUFOREA. And if you look those up on their website, you will find a video of how to use a nasal spray. Think like a pharaoh. cross your arms, and then use your right arm for the left side of your nose. And you're aiming to treat the inside of the outer wall. So you put one puff up, one puff back, wetting as much of that lateral wall of the nose as possible. Change hands, same the other side. Don't sniff. Leave the spray in your nose. Tiny little hairs called cilia inside your nose will move it from front to back. That will take 10 to 20 minutes. That is when the spray works. If you sniff it back, you'll waste it. If you taste it, you waste it. So be patient. Don't blow your nose within the next 20 minutes, although you might want to. Let the spray do its work. And if you do that, it should help. Other tips are keep that spray next to your toothbrush, so you remember to use it every day, and use it just before you clean your teeth in the morning. Most sprays these days are once daily, so that's probably all you need. But if you have a twice daily one, same again in the evening.
Are there any safety concerns with corticosteroids, both inhaled and systemic, for certain groups of people?
There's very little safety concern over intranasal corticosteroids. I would always recommend that ones with very low systemic bioavailability are used. And those are things like mometasone furoate, fluticasone furoate, fluticasone propionate, and cyclesinide. Use one of those and you are fine, whether pregnant or breastfeeding. The danger comes with systemic corticosteroids. Depot injections are not recommended for hay fever. They are not actually particularly effective. They do not last long enough for the hay fever season, and they are associated with significant side effects. The risks outweigh the benefits. If the patient is so bad that they need systemic corticosteroids, these should be oral, taken as one dose in the morning, 0.5 milligram per kilogram, for a few days only. And that might be necessary for something like getting married or a big event in one's life, but that is all that should be necessary. And then those patients, the patients who are not well controlled on the top medication, and the best medication for allergic rhinitis is an intranasal spray with both a corticosteroid and an antihistamine in it, a combined nasal spray. If you don't respond to an intranasal corticosteroid, that's what you should have. If you don't respond to that, then you should be considered for allergen-specific immunotherapy, which is the only treatment that alters the course of disease.
Okay. And how does management change if you've got asthma or COPD?
All patients with hay fever should be looked at to see if they have additional asthma. There should be the usual questions for asthma, and some kind of peak flow or other functional measure, spirometry should be made for all of them. And they can be treated in the same way, because the intranasal corticosteroid adds very, very little to the inhaled corticosteroid. The surface of the lungs are like a tennis court, so the absorption is large from the lung. The nose is a tiny surface area. The absorption is very small. What's not absorbed is swallowed, goes to the gut, and is metabolized first pass by the liver. So adding on that treatment does not add to the corticosteroid burden significantly, but can add to the therapeutic effect quite magnificently. It makes a big difference in asthma if you treat the inflamed nose well.
Thank you. And how can a GP ensure that a patient isn't over-medicating because they've got persistent symptoms?
Well, ask them. One of the things that patients tend to take that they won't always tell us about are decongestants, and they are another no-no. They open up the nose much too wide. It's not meant to be a wide open channel. And in the end, the nose stops listening, not only to the spray, but also to the impulses from the nose that cause a nasal cycle. Normally we breathe through one half of our nose mostly at a time, and that alternates every 4 to 6 hours, probably because of the burden of that environmental challenge that the nose gets all the time. Decongestant use abolishes that, and you may end up with a very, very swollen up nose, and that's rhinitis medicamentosa. And that can be very hard to distinguish from very bad hay fever. So ask your patient whether they're taking decongestants, how many of them they get through. You may or may not get a proper answer, but that is the thing to worry about over-medication. If your patients are not controlled, think about immunotherapy, because these days NICE has approved sublingual immunotherapy. That's tablets under the tongue for tree pollen, for house dust mite, and for grass pollen will come soon. And these are very much safer. They only require the first dose to be taken in the allergy clinic or the ENT clinic under supervision. And then they can be monitored at home. They're taken every day at home. And this is where there can be wonderful interaction between the GP and the specialist to the benefit of the patient. 3 years treatment results in very good therapeutic effect during those 3 years, plus the effect lasts after that for at least 2 years. It's been tested for 2 years. We don't know further than that, but we suspect it goes on much further. And this is really different to any form of pharmacotherapy, because this alters the way the immune system perceives pollen. It begins to perceive it as harmless and stops that reaction. And for many people, hay fever is the first step in an allergic career, which goes hay fever, perennial rhinitis, asthma, and worsening disease. And if GPs can interrupt that career, they will save the patient a lot of therapy and misery, and they will save a country a lot of money.
That's interesting. So immunotherapy is the long-term management option.
It is. And sublingual is not that expensive. It costs, I think, about £1,000 a year. Especially that's if you do it, you can do for pollen, you can do it pre-seasonally for about 8 to 16 weeks, and then to the end of the season for 3 years running. That would cost about £3,000. And that is nothing compared to the biologics which are now being used in severe asthma.
That's interesting to know.
So it is well worth thinking about. And unlike the biologics, it does appear to have some curative potential.
And when should GPs refer to a specialist?
Uncontrolled hay fever should be referred to a specialist. And any of those red flags, fluid coming down one side of the nose, could be cerebrospinal fluid. Good idea to see the ENT surgeon about that. Unilateral obstruction might be a tumour, a polyp. All those red flags, I suggest referral, plus uncontrolled hay fever.
And if there's one thing that GPs could do to handle the hay fever season to make sure that outcomes are better, what would it be?
Contact the patients with hay fever. Remind them to start treatment early. If you start 2 weeks before you get symptoms, your whole hay fever season is flattened out. And perhaps say, let me know if you want a prescription. It'll be at your local pharmacy for you to pick up, or go and buy it over the counter. So the early bird catches the worm, or the early bird catches the benefit in this case. So start early and persuade them to use their treatment regularly.
Great. Thank you so much, Glenis, for joining us today. Thank you very much for listening. This episode was produced by Jude Owen. Don't forget you can claim CPD certification for this podcast if you head over to MIMS Learning website at mimslearning.co.uk. And do join us next week for another episode of Clinical Education. Thank you.